Good afternoon. Yes. I am Manish, and amazing talk since morning, and it's really tough to kind of live up to that expectation, but I'll try my best. Okay. So, just like any engineer, I would say I went to IIT Bombay for my engineering. I thought that's the best thing to do. Yeah, sure. And then, again, like after 4 years, I was lucky enough to kind of graduate. So I went to another company and, started working over there. And I worked for a while. And my dad is a doctor. He has his own hospital. And every time I'll go back to his hospital and say, Dad, like, why don't you do this better? Your patients are waiting far too long, so you can do something over there. Oh, you can, this is the way you can increase your revenue. Oh, yeah, there is a chances of leakage over here. Why don't you fix this? And, one fine day, I still remember it was around 10 o'clock and he had just come from his day-long work, and he was eating. And then I was on and on. Like, oh, I have to go back in 2 days, so why don't we let's fix a couple of things? And he's like, you know what? I am a doctor. Let me do my job. If you think you are a manager and you can do any better, then why don't you do it yourself? And that kind of, I came back and to my own work, and but I got thinking that and what I used to do for work was that I used to basically improve the business process of large companies. So for example, like I worked with Lenovo when they kind of took over the entire ThinkPad division from IBM, so how to integrate the entire process. I also and many like that. And then one of the things I realized was the healthcare, the way it is right now. Once you reach the hospital, I think pretty much most of the things can be fixed, right? I would say 98 to 99% of things can be fixed today. I mean, that's how has been the improvement in science. But the moment you leave the hospital, then what happens, right? It's completely left onto the individual himself, and then there's a big lack of knowledge, and then so on and so on. I thought that with this my experience, can I put that in healthcare? And then when I started thinking deeper about it, then I realized that without any healthcare experience, no one will listen to me. So I went to ISB to do my healthcare management. So at least I have something healthcare in my pedigree. And then, just like any, school, there are a lot of competitions, and now there are a lot more, but, this was like one of the early days, something called Hult Prize, and we were lucky enough to kind of participate and go into the top 6. And there's one quick video which I would like to show you for for the finals.
I love the Hult Prize. You, in so many ways, represent the future. The Hult Prize is about more even than the solution to the problem advanced. It's about how the world has to work in the 21st century.
Sometimes there's these ideas that they sound a little out there on first blush, but then you realize that there's actually quite a bit of substance behind it.
The youth are not the leaders of tomorrow, they're the leaders of today, and I think these are the people who are going to be able to show us what the future really is about.
There is a sense of citizenship, and there's a sense of actually acting on your presence and existence in your community.
You've heard all of the entrepreneurs in the NGO space say that charity is not enough. Well, if charity is not enough, then what is? It's business. And that's why I'm so pleased today to tell you about 6 great teams.
Tooth decay affects 2.4 billion people. Xylitol gum intervenes in this process. We, Harambee Vision, believe we can change all of this by locally manufacturing and distributing eyeglasses in urban slums.
This significantly improves the quality of life of every patient with a wound.
Using bees to screen for diseases in urban slums.
The REACH program, the first and only diabetes monitoring program for urban slum dwellers.
The journey of NanoHealth, a social enterprise that aspires to right-size healthcare for urban slum dwellers, bringing cost-effective healthcare right to the doorstep.
We believe we have come up with a good solution which can be implemented.
Judges, we'd like to ask you to make your way backstage. Audience, we'll be back with a few closing remarks, and we'll do the presentation of the 2014 Hult Prize.
The judges have selected NanoHealth from the Indian School of Business.
Well, thanks. I mean, I still get goosebumps every time I see this video. So, well, the whole challenge was that how do you solve the problem of non-communicable diseases, especially focused on the poorest of poor. And so we went a little deeper into it, and that why is it such a big problem? Like, why more and more people are dying out of this non-communicable disease like diabetes, hypertension, and cancers and so on, year over year. So then we figured out actually there are three problems. The first one we call it as underdiagnosis, where the people just don't know that they are actually sick. I mean, and I think early on we early speakers talked about people not getting screened at the right time, right? Then the second is treatment. Like, even to find the right treatment, but let's say about the poorest of the poor, it's still very difficult. I mean, the best of the hospitals are not available for them. And the adherence or compliance is a universal problem. And any thing you pretty much take, that's a huge problem. And then what happens if you don't kind of manage them? Then there is a premature death. And we'll talk about the extent of this problem as we move forward. So just like any problem, this is like the most of the problems are actually hidden. So what you see at the top is like a very high risk is actually where there are symptoms which you can see, right? But what happens is if you see the care-seeking pattern in terms of the people how they are actually going out and requesting for or going to the hospital or clinics and seeking care, you say for the topmost, I mean, they are very prone to that. So it's very, very difficult to actually, and the next one is actually, this is the place where the people are actually seeking episodic care. I mean, like, for example, you gave an example of, I take medication for 3 days, and if the doctor has suggested for 5 days, and then, but these problems that I am talking about, so-called non-communicable disease, like that's a problem, 10 times bigger. And I'll tell you why. Well, these are some of the recent studies, like more people die out of hypertension than all the infectious disease combined, right? So every 12 seconds, someone dies out of heart attack in India. Every 3 seconds, someone actually gets a heart attack. I mean, thanks to the, I would say, improvement in the healthcare that, a lot of people are saved even though they have heart attack, but that's the mortality rate we are talking about. One of the studies from WHO in 2013 that came up said that in India, in Southeast Asia, there is a greater than 25% chance of everyone dying out of non-communicable disease than otherwise. So in many ways, I know that how I'm going to die, right? So I mean, that's how big a problem is, and that's where like President Clinton said, this is like the biggest health problem of our generation. Okay. This is just few numbers, right? Like this is for India, and we have done a great job in terms of addressing, I would say, the problem of communicable diseases like flu, diarrhea, and so on. I mean, the companies like Pneumocare and all is doing an excellent job in saving neonatal deaths, right? And but what's happening here? I mean, you can see the number of, and this is just the number of deaths that happens. And the other thing apart from that happens is that the people die early. So it's like most of the deaths are before the age of 70. So that means their productive years are gone. I mean, it's also said that 4 to 6% of the country's GDP in India is lost because of this. I mean, that's how big the problem is. then why it's getting bigger and bigger, and still I would say like no like a significant, I would say, solution in sight. One of the thing is like they are very different from the way our entire health system is designed. Okay, like our health system is designed that the doctor is there and a patient comes and he will treat. But here the diseases we are talking about is asymptomatic. So the patient does, or the user just doesn't know that there is something wrong with that person. So he doesn't know when to go to the doctor, right? The second is, if you have a flu or if you have a fever, I take pill for 4 or 5 days and I'm good. I don't have to worry about that again. But these diseases are not. They need long-term management. Once I am hypertensive, once I am diabetic, I mean, it's very unlikely that I'll get rid of that medication. Okay, so it's again very different from the way we are used to taking medication and we are used to approaching healthcare. So what do we learn? So it's like the reactive, it's like focus the current health systems. I mean, pretty much worldwide it's similar. I mean, it's a cure on the symptoms. Once the symptoms arise, we are going to address that problem. And I think we have perfected that art, that we are very getting better and better every day. The second is fragmented. Like, how do we talk about, like, once the doctor says that, hey, this is the medication that you need to take for the next 10 days, 20 days, 3 months, and there is nothing that actually manages or helps the individual to do that over a period of time. And the doctors complain that, hey, the next time the patients go back, at first the rate of people actually going back to the doctor on time is very abysmal, in single digit maybe, or lower double digit, like 20-30% on time. Even when they go back and they do another check, if the readings are not in control, then the patient blames doctor, and the doctor will blame that, hey, you didn't take the medication or you didn't come on time. So that cycle kind of keeps revolving without a solution or help for anyone. So what is the solution? What did we do? I mean, understanding that this is a problem, we said that, okay, we need to come up with a solution that is proactive, that is coordinated, because we learned that there are multiple health stakeholders in the entire health system. There are patients, there are doctors, there are hospital management, there are like a family members, there are nurses, and so on, right? So there are pharmacies, labs, and I think there is only one way in which you can actually make a difference is you can start making sense of all that data and then come up with something which is useful for the patient. So we started with a very simple thing, that there is a health assessment that is done in the most convenient manner. I mean, that's where again the design thinking comes up, that the convenience actually is a huge factor in it. Like, would you expect someone to actually come out and do a health checkup for a problem which they just don't think that there is a problem? Never. I mean, it doesn't happen. Now that awareness is improving, but still it's abysmally low, and I'll share some numbers with you. Then, I mean, like, can we do it very close to you, right? And so yes, we did that. And then basically what happens next, right? Then if the readings are in high or low, I mean, are high, then you should actually go to the doctor. But again, that is very low, and some of those numbers I'll just share with you. And then once let's say that the person actually goes to the doctor confirms the diagnosis, writes the prescription, then there is a whole continuous loop that begins, okay, which is like your periodic monitoring happens. Then and this we are not talking about like a days or months. It's about like years over years. So this will keep happening. It's a continuous process, okay. And then and then basically whenever you are not in control, you basically go back to the doctor, and then again the prescription changes, everything, whatever needs to be done, that happens, and then the process keeps moving on. So to actually so what we did was, at first we understood that it is a multi-stakeholder problem, right? And everyone looks at the same patients in a completely different way, right? A doctor is there, I mean, he looks at last couple of, I would say, reports and will prescribe the medication. The lab person, I mean, just the only thing that they need is like, a blood sample or a sample, and, they will just put out a number out there, and their job is done. And often basically the link between the two is left directly on the doctor or the patient. So at first, we made sure that every one stakeholder is linked to each other. So the information is captured and the right stakeholder is nudged at the right time that, hey, this is what you should be doing as a next step. And we'll see how that happens. I'll skip for now. So how does it work? I mean, so the first thing what happens in the entire health ecosystem, every information is captured. Okay, so from various point of care devices, we are point of care device agnostics. I mean, the information, if you have it, we'll be able to put it into EMR, EHR. Okay, the next, that information is, we made sense out of it. There is a rule engine, we call it recommendation engine, and and that tells you exactly what should be your next step, right? A very simple example is this. So we were, there was one individual, we measured his blood pressure, and basically for the first time he came to know that, he was actually hypertensive. But the doctor suggested that we should not be doing, giving a prescription or medication immediately. So, for the next 3 months, we measured. I mean, this longitudinal data itself, if you go ahead and ask for, I would say the best of the hospitals today, I mean, that's not very easy to find, right? Then, both the system, looking at this, the doctor recommended, and if you'll see the system itself recommended that, hey, it's time to go for a doctor consultation, it's time to go for do some additional tests. So basically, this is what I'm saying, that, we make sense of the data that you have, that has come for that individual, and then basically specific recommendations are come. Now, and then basically, and these recommendations are both for the users or what we call as a health coaches, which kind of start nudging that individual that, hey, you need to move, you need to go to a doctor, or you need to go do these additional tests, and so on and so on, right? A good example of that actually happened to me. I mean, my health coach came to me and said, Manish, 1 year later, before when we had measured your, blood test, your lipid profile was a little on the higher side. I think it's time to go for another test. I mean, because that was on the of my recommendation. And basically, I said, yeah, that's fine. The other thing that we learned during this process was like money is not a problem. Like the people are ready to invest the money on the test once you give them the right information in the right way. Okay, so I got the test done, and I found out that it was, it didn't increase, but it has definitely not reduced as well. And then my next recommendation was visit a doctor. Okay, so I think this is what I'm saying, and it keeps moving. The moment you visit a doctor writes a prescription, the next recommendation, hey, you take your prescription. The moment you order a prescription, it tells you that, hey, when do you want it to be the refill date? And then on that refill date, it will start prompt you again. So it's like about what is called as a care continuum. After each step, it keeps nudging you for the next step. Now, some of the data, I'll share with you some of the interesting things that we have found. Now, this is the data for 10,000 people. Again, this is live data. We found out that there were 39% of them were at a high risk for one of these four, like hypertension, diabetes, oral cancer, breast cancer, and cervical cancer. And we informed them, hey, you should be going to a doctor, this is something, wrong. The doctor will actually confirm your diagnosis and so on. And guess how many people actually went? This is the problem I'm talking about. Today, even the corporates give you, like most of the corporates will give you free health checkup. Will give you, like health insurance. Do you know approximate what percentage of people actually get it done? It somewhere lies in 20 to 30%. So, that's how even free health checkup, people just don't go and get it done. The other big challenge is this, what you see, underdiagnosis, which means that, like, especially if you see for hypertension, it's very high. Like people have no clue that their blood pressure is on the higher side. And one fine day, it just comes in a very reactive way, and and that's bad. And I think the best way to understand is to ask yourself, when was the last time you went ahead and actually checked your blood pressures? Everyone above 30, age of 30, they should definitely do it periodically. These are again some of the results. So basically, this is the data from August 2018. Say the people at very high risk and high risk, what you see, and then how actually there has been increase in numbers because more people have joined. And these are all the people in very high risk. I call it they are ticking time bomb. So they are like, like literally they can fall any time. So, but the biggest impact has been, though the age, this is like approximately 1 year, though the age of the people have actually increased by 1 year, but you can see that the impact has been, not only the same, but it has actually been lower. This is what I say is my holy grail for the entire effort that we have put in. So this is what I call as employee engagement report. So here what you see is like the complete risk profile of the entire organization and or the entire cohort, and then when was the last time they actually engaged with the health system. So which means that someone over here, is, if he's at a very high risk, and if he or she is not engaging with the health system, with a doctor, and then he or she is the one who is most likely to actually fall down. Right? So we are actually mapped that with when was the last time they actually engaged with us. And this we are talking about like close to 70% of engagement in last 3 months. And this is like, very, like unheard of. It just doesn't happen. And how we have been able to achieve this is by two things. One is by creating the right nudge technologically for the right person. So now you say that, okay, hey, you need to visit a doctor for your high cholesterol. We're not saying that you go in and visit a doctor. He'll never care. And the other is what we call as a human touch. So only by keep pinging the people that, hey, you do this, you do that, doesn't work. There has to be someone who will be explaining that, this is the reason why you need to do this. So that human touch is as important as the technology. But technology makes it scalable. So tomorrow I need to do it for 100,000 people. Piece of cake. Yeah. Well, this is some of, the first time, when we identified someone's blood pressure was high, and over a period of time you have seen that. And what is interesting to see is that and these are the symbols which tells you actually that when was the doctor, the person visited a doctor. And immediately after visiting a doctor, you can see that again the blood pressure came in control. This is another very interesting example. You can see that when it was high, very high, and the moment the person actually visited a doctor again, is over a period of time it started coming down. Right? Now, if you talk about, this is from the solution perspective, and I think Pratyusha mentioned that, this is all good, it impacts, saves a lot of life, at least 20 people, I know that after just from basic screening, we have been able, within 2 to 3 weeks, they have to put a stent. So, that's the real impact which I'm talking about. But like, who will pay for it? Right? Because there has to be like a whole business perspective to it. So that's when we figured that the biggest advantage is, of course, the health-wise is the individual, right? Because, they are healthier, but fortunately or unfortunately, they just don't care enough at this point of time. But when we start working with corporates, like one was, of course, that, my employees should be healthier, but their biggest benefit was actually the claims. So we have been able to prove that if anyone is leveraging our solution, the health claims have actually been able to reduce significantly. Okay, while you go and talk to any large organization, they will say that my claim is rising from 120, 20% to 30% year over year, and we claim that we will be able to reduce by 10 to 15% at least in the first year, just by simple health management. So that's quick. So we work with 3 different business segments. One is we continue to work with large NGOs and large NGOs and government for their community health management. So again, it's right from the basic community health to the tertiary care, the entire end-to-end solution. Next, we also work with the corporates for their health management. I would say the basics, the good part is that the humans are human. So, like if you can manage 100,000 people, you can definitely manage. Just the way you offer is a little different. The way you communicate, the value proposition is a little different. And at this point of time, we also offer a solution for, I would say, the clinics and hospitals. So basically the entire, not only the health management, but the entire billing. For them, the billing is the most important thing. So yeah, billing, appointment management, everything that you can technically imagine. So yeah, that's a nutshell. Yeah, so okay, cool. So I think the rest of the questions I'll take at the end, right? Thank you. Thank you, guys.